for metabolic surgery in Mumbai. I'm Dr. Amrit Nasta, a bariatric surgeon, and today we are going to discuss a very important disease related to obesity. Over the last few weeks, as we have been conducting one after another webinar, we have discussed so many important obesity related diseases. We have done diseases in women, polycystic ovarian disease, liver diseases, bone diseases, heart diseases, and so on. But today we will discuss something even more important, and that is cancers related to obesity. Did you know there are so many cancers? Cancers of the breast, cancers of prostate, colorectal cancers, esophageal cancers, and so on, which are directly linked to obesity. We never thought about it like that. We always thought obesity was a lifestyle disease, and if you the heavier you were, the healthier you were. It's not so. There are a lot of cancers which will be thrown light upon by some of the eminent people from Mumbai today. So we have with us today Dr. Advani and Dr. Raman Goyal, who will be discussing this concept of cancers related to obesity. Our first talk today will be by Dr. Advani, and he is a senior oncologist. He is the director of the medical oncology department at Jaslow Hospital. He is also the former head of oncology at Tata Memorial Hospital, and he has numerous awards and accolades to his name, ranging from Dr. B.C. Roy Award, Padma Shri, Padma Bhushan from the Government of India, and so on. The list is endless. So without taking any more time, I would like to bring to us Dr. Advani. Sir, please take over and enlighten us on the different cancers and their links to obesity. Over to you, sir.
Good afternoon. First of all, I must express my thanks to the organizers for giving me this opportunity on a topic which is so important to all of us. We are really committed to the cancer prevention, cancer treatment, and the cancer overall outlook. And that's why our focus is on every aspect of the cancer. Now, I'll show you one of the slide. Can you show the slide, please? Kritika, can you show the slide?
Yes, the slides have been shared. Should we move on to the next one?
No, I can't see.
Sir, the slides are visible. Somebody from your side can set it up.
Yes, okay, fine. So it has come now. So here you can see that among the cancers, there are many cancers which are preventable. And I think I really believe that if we take care of all these preventable cancers, cancer will be almost half than what we are seeing. Look at it, tobacco causes tremendous amount of the cancers. The diet plays a very important role in induction of various cancers, and the obesity. Just count these three things. You will find that 65% of the cancers can be prevented if we eliminate tobacco from our use, if we modify and take only the healthy diet, and if we prevent the obesity and overweight. I think these are the things which are very, very, very evident from this. And I think it's a very important factor. Next slide. The important thing is that we know what does the obesity does to our body. It affects almost every organ. I think just now Amrit told you that you have been discussing various aspects of the obesity. And look at it. It affects almost every organ. Obese people have a really the preventable death due to the obesity, whether it's because of the fatty liver and cirrhosis, or whether it's because of the stroke, or whether it's a heart condition, and so on and so forth. So you can really see that obesity plays a havoc to our body. Next slide. And the something which have come up about the cancer is very clear on this slide, that obesity is related to particular type of the cancer. It is not that it affects every type of the cancer will increase, not at all. but particular types of the cancers are related to the uh, cancer and the obesity. There's an interaction. And so you can see over here that we have a meningioma, which may not be a cancer, but is a tumor growth. And we have the ovarian or endometrial carcinoma. We have the breast cancer and the pancreatic cancer, which are related. They are considered to be, the obesity is considered to be the risk factor for developing these cancers. Next slide. And therefore, one could again see from this slide that the breast cancer, particularly the post-menopausal breast cancer, is twice in the people who are obese as compared to the normal. Similarly, the liver and kidney cancer, they are also twice as compared to the lean person. Endometrial cancer is 4 times more. What a impact it has got. The moment the patient walks in my clinic, in our clinic, and she is obese lady, and we know that we are dealing with a gynec problem, particularly the endometrial carcinoma. And similarly, you can see the other cancers also to relate it. But the endometrial carcinoma really gives you a very typical, all the patients with the endometrial carcinoma, they have obesity, they have hypertension, they have diabetes. So every part of the obesity is clearly identifiable in these patients. Next slide. So important thing is that up till now, there has been a tremendous amount of the research which has happened, and we clearly now know that there is a convincing evidence for some of the cancers, and for others, still it remains probable. One of the cancers which I told you is the endometrial cancer. It is 4 times more in obese people, irrespective of the age. And if you have the early age obesity, then the chances of endometrial cancer is still high. Similarly, the post-menopausal breast cancer, not the premenopausal breast cancer, but post-menopausal breast cancer is definitely twice as compared to the normal thin and lean person. And of course, other tumors also, like colorectal cancer, renal cell carcinoma. So we have enough evidence to suggest that if we prevent the obesity, we can prevent many of these cancers. Next slide. So now we will see what is really happening. I'm sure you must have seen all these things before, that how over a period of time, the obesity is increasing, not only in US and Europe, but also in the Asian countries. It is increasing, definitely on rise. If you ever go to US, you will find almost 50% of the population is overweight by just looking at them. It's so, and also I must admit that whenever I go over there and we sit down and eat the lunch, we laugh. Why we laugh? Because our plate is only about 1/4 the full with the food as compared to the 4 times more for all the Americans who are eating. They eat so much. Even in the lab where I used to work, the ladies, they used to come, the big cake and all the time they are eating. They take a breakfast. After 2 hours, they go for something to eat. Then they bring in the chocolates and the cakes. They go on eating all day. And they are so not conscious about obesity at all. And here you can see that in US particularly, 1 out of 3 adults is obese. And even in children, 1 in 6 children are obese. Next slide. And you can also see that how they consume the junk food, which is because of the marketing. And that is associated with the obesity, irrespective of the age, whether it's 11 years or 20 years. You have the equal chance of being obese, particularly in the US. Next slide. I think also the fact remains that as the nation becomes more and more wealthy, the incidence of the obesity increases. And here you can see that from 1960 onwards, the obesity incidence is rising both in the males as well as in the females. From 1960 to 2000, the increase is really very significant. So the obesity is going to give us the problem. Next slide. And in terms of the cancer, also how we judge that yes, it is because of the obesity. Here you can clearly see that the cancers which are not associated with the obesity or overweight, they have come down over a period of time. Many cancers have come down, but if you look at them, they are all not associated with the obesity. And those who are associated with the obesity and overweight, they are over a period of time. From 2005 to 2014, they are increasing in incidence. So I think this clearly shows a real link between the obesity and the cancer induction. Next slide. Now, how does this happen? Why the obesity? What obesity has to do with the cancer development? I think obesity, there's a lot of adipose tissue. The fat is more as compared to the lean muscle mass. And therefore, it has got a lot of adipose tissue. And all these adipose tissue bring about some sort of inflammatory reaction. And whenever there's an inflammation, there's a excess of the insulin production. And ultimately, people develop the insulin resistance. So the level of insulin is very high in these people. And also, because the fat is more, these fat cells are also producing the estrogen. So you have more than double the estrogen in your body. And all these two factors, insulin growth factors, as well as the estrogen, can play a very important role in controlling the cell proliferation. Next slide. Here I can show you that what happens really. It's very clear that the normal cells, they are all very well, easily maintained. You can see that they are a controlled proliferation and controlled layering of the normal cells. And when the inflammation occurs, more insulin, and it stimulates these normal cells. When there's an increased lipids, there are various cytokines which are released from the adipose tissue. They also stimulate these normal cells. Insulin signaling, insulin growth factor receptors, they are stimulated. And of course, the adipokines. So all these things, they stimulate the normal cells and bring about the change in the proliferation. And you can see then that there's an irregular growth of the tumor cell, or the cancer cell become the tumor cells, and it loses the normal inhibitory power. Because normal cells, they are, because of the contact with each other, they try to maintain the balance, inhibitory as well as stimulatory. While here, the cells become abnormal, there's no inhibition, and therefore they become uncontrolled. And what is cancer? Is nothing but the uncontrolled proliferation of the cells. So that's what is the cancer it is. So you can clearly see what is happening to that. Next slide. Also, at the level of the cytoplasmic mechanisms, also there are definite changes which ultimately leads to the target cells being transformed. So you can see over here that in obesity, there's a insulin resistance, and there's a leptins, and there's a tumor necrosis factor and IL-6. All these are stimulated. They have the receptors, and they go and stimulate these receptors, like IL-6 receptor, tumor necrosis factor receptors, adipose sign R1 and R2 receptors, and similarly insulin growth factor receptor. You can see now that how these chemicals, which are overacting, they stimulate the receptors. And once the receptors are stimulated on the cell surface, they bring about what we call it the chain reaction within the cytoplasm. and from the surface, the signal goes to inside the surface. It travels through the cytoplasm, and where does it go? It goes to the nucleus, the DNA and RNA there, and it altered the cell proliferation and the death. It also not only alters the cell proliferation, but also it gives the cells a different migration capacity. They can migrate in any place they want to. And also they can invade the tissue. But normal cells don't invade the side-by-side tissue, but here they can invade. So that's why the typical characters of the cancer in terms of migration, in terms of invasion, and in terms of proliferation are really induced, all because the basic cause of the obesity. So I think it's very important to understand. Next slide. What is the process of induction? And here you can see that how the cancer is promoted in the obese patient, maybe because of the endogenous sex hormones, the insulin resistance and hyperinsulinemia, the adipokines and cytokines, and of course the chronic inflammation, which ultimately bring about what we call it carcinogenesis. What is carcinogenesis? It's nothing but a process by which you stimulate or transform the normal cells into the cancer cells. Next slide. I think the important thing is again to understand that all these factors ultimately, where do they act? They act on the target cells and the tumor development occurs. Next slide. So what I have tried to tell you up till now is what is the process by which obesity makes the patient cancer prone. I think it's very important. So if you are thinking about prevention, you must understand these. And if you are able to understand that, I'm sure you will be able to guide the people to avoid the obesity, which I'm sure my colleagues will explain later on. So look at the endometrial cancer. I said it makes you obesity, makes you 4 times predisposed. And endometrial cancer is not an uncommon disease. We see day in and day out. It's the 6th most common cancer in the woman worldwide. Next slide. And it is very clear that look at the facts that even mild obesity can cause doubling of the cancer risk. Moderate obesity 4 times. There's also called the central obesity, which also increases 2-fold increase. And the most important thing is that if your early life there's a obesity, the risk of endometrial cancer is tremendous. So I think you can really see that how the parents should take care of the children to prevent the obesity at the right age. And of course, later on also, this has to be prevented. Next slide. Similarly, here you can see that if you prevent the obesity, 50% of endometrial cancer will disappear. I think it's a huge number which you can prevent by just controlling the obesity. I think this is the most important factor which all of us have to understand. And I'm sure the awareness about obesity and its relationship with the cancer is almost zero in most of the people population. Even in US, among the adults, the awareness of this fact is hardly about 10%. 90% are unaware. They feel that obesity has nothing to do with the cancer. Next slide. Breast cancer, which amounts almost about 1/4 of all the cancers seen in the ladies. Next slide. And you can see over here that obesity causes almost 10% of the postmenopausal breast cancer, and 14% can be attributed to the obesity. So again, a big number. Yeah. See, when we say 14%, what it means? It means 14% of all the cancer postmenopausal. It's a huge number. It's in lakhs and lakhs world over. So you can really prevent so many numbers. You can prevent or save so many lives. Next slide. I must say that particularly in the postmenopausal, there's an increased risk, and this is all hormone receptor related disease. It is not those people who are using HRT, it is not affecting that. And also, it supports the hypothesis that estrogen must be a very crucial link between the cancer development and the breast cancer. And we all know what I have told you already, that adipose tissue play an important role. Apart from this, that I have told you that how the obesity is linked, how the mechanism of action, and how the association has been observed. The most important thing also which remains, that even after you have treated the patient, what happens to them? I think this will be evident from the next slide, that what happens to them. Obesity and survival after the cancer treatment is different. Can you believe it? But it is real that people, suppose the patient is obese, he has recovered from the breast cancer, he has received all the treatment, his chances of relapse is double in obese people as compared to non-obese people. So one of our important advice to all our patients following the completion of the treatment is, don't put on weight. And if you are obese, reduce the obesity. That's our instruction. I tell my patients, walk 5 kilometers every day after the treatment is over. Make sure about that. Do some yoga activity and all the activities which you want to do. But make sure that your weight is under control. I think this is very important. And this is irrespective of menopausal stage. Even the premenopausal, if they are fat, they are more liable to have the relapse. And you can see this from the next slide also. But look at the survival in non-obese patients. A big number, 557 patients were followed up. Non-obese definitely have a better survival as compared to the obese people. So I think, friends, what I have really tried to cover in this 15-20 minutes, that the obesity is our major enemy. Just like we are suffering just now from pandemic of the virus, we may end up with the trouble of pandemic with the cancer because of the obesity. So we have to be careful now. We should not adopt the similar lifestyle as the people are living in US and Europe. The lifestyle which is full of energy. They take so much of the energy within them that they are not able to cope up. So we must use our own culture, our own food habits, which are so good. I mean, you go to some places like, go to Kerala and South, you will hardly find obese people. There are no obese people over there. They are very hardworking people. They hardly eat any oily substances. So you can see that we should adapt these habits rather than the habits from the USA and UK. And therefore, my sincere advice to everybody is that you guide your people, guide your patient to make sure that they take the right diet and control the obesity or prevent the obesity. By preventing the obesity, you are going to prevent the large number of cancers which otherwise can affect the patient's life. Next slide. Thank you very much.
Thank you, Dr. Advani. Thank you so much.
Yeah.
I think you could not have put the message in a more clear way than you have about all the cancers and how obesity has an impact on the body in relationship to them. One of the very interesting slides that I noticed was you were saying that how non-obesity related cancers have started reducing and obesity-related cancers have started increasing in incidence. That is something to look forward to. So as obesity is increasing, even the related cancers are increasing. Sir, we will take questions at the end. I'll just ask you one question before you go. In your practice, do you feel that the longer the duration of obesity, more the cancer? Like, do young people who are obese at a younger age, do they come up with cancers like endometrial cancers at an earlier age?
Certainly, I think this is very clearly seen that we see in our clinic that people who are obese, they are young when they come with endometrial cancer. The lean and all, they probably get the endometrial cancer at the age of 70 and 80. But fat people, you can make it out from right, they are fat, they are eating and enjoying themselves, and they'll end up with this trouble. So I think there's no question that these are the things you probably don't need the statistics. You can see them.
Thank you so much, sir. I would now like to invite Dr. Aman Goel, who is the Director of Center of Metabolic Surgery. He's also the President of IHES. Sir, please take over your talk on bariatric surgery and its impact on cancers. Take over, sir.
Yeah. Thank you, Amrit. I think it's an amazing discovery today when Dr. Advani showed the first slide, how many cancers are avoidable. So, I mean, obviously we are talking of obesity today, but if you add obesity to tobacco, alcohol, physical inactivity, I believe about 65 to 70% of the cancers can be avoided. And it's a humongous number because for the families, the cost and the discomfort and the loss of their near ones is such a big issue. So I think I'm very happy that Dr. Advani is here because he's an authority on cancer, and he has made my life easy because he has spoken so much in detail about the mechanism, how the obesity causes cancer, and how the risk can be reduced if we lose weight. So greetings from our Center for Metabolic Surgery. I am Ramin Goyal, and I'm going to talk about impact of bariatric surgery on cancers. Now, when we started doing bariatric surgeries about 20 years back, everybody thought that it's like a cosmetic surgery. And people would not get it done unless they are 170, 180 kg or more. And then they were the difficult cases to begin with. But now we have come to a situation where we have realized, and it's evidence-based, that if timely bariatric surgery is done, not only treats diabetes, sleep apnea, blood pressure, reduces stroke, reduces kidney failure, but it also reduces something like cancers. Now, this had always been on the fringe of bariatric surgeons. So when we were taking talks with family physicians and other surgeons, the cancer is just one slide. But today, after listening to Dr. Advani, I believe this will occupy center stage, because if 30% cancers are happening related to obesity, and bariatric surgery can certainly help. So in next few minutes, a short presentation, I'm going to talk about bariatric surgery and how it helps in cancer reduction or prevention. So these are the Indian guidelines. And as Dr. Advani has mentioned, one of the important factor is raised insulin. So the diabetics who have insulin resistance, in those patients, we can do a bariatric surgery even at BMI of 27.5. Primarily to treat diabetes, these patients hardly lose 7, 8, 10 kg weight. They don't lose 30, 40. But on top of it, the insulin resistance, in one of the studies that we had published when I was in Bombay Hospital in 2008, we did the study and published in 2011. The insulin resistance reduced by 90% within 6 months. And if insulin resistance is the cause of one of the cause of the cancers, then it will certainly going to help. Just to show you 2 slides about the outcomes that are seen, this is our own publication with Amrit as the primary author, that at 1 year, patients have lost 87% of their extra weight with sleeve and 97% of their extra weight with the gastric bypass. And even after 3 years, their sleep patients are still lost 72% weight, and bypass patients have lost 85% of their extra weight. It is substantial, because if somebody has, say, 60 kg overweight, we are looking at a weight loss of almost 50 kgs within first year, and it is maintained long term. And it's not about weight loss. In another study that we did on sleeve gastrectomy 5-year follow-up, we have shown that at 3 years, diabetes resolution happened after bypass, let's say 92% patients. So when we say resolution, that means these patients don't need any medicines for diabetes. They may need medicine for anything else, but not for blood sugar control. And even after 5 years with just sleeve, 64% patients don't need medicines for diabetes. This particular study was for sleeves, so that's why bypass is not there. So this goes to show that how the mechanism that applies for diabetes also applies for cancer, and we will discuss this a bit. There are multiple studies. Dr. Advani has shown it beautifully, but there are few studies which I have brought out. So after bariatric surgery, so what they did was they had two groups. One groups, meshed groups, obese patients, where they did bariatric surgery, and another group they did not do a bariatric surgery. And they were followed for 15-20 years, because cancer cannot be diagnosed in 1 year of follow-up. And they found that in post-surgery group, the cancers were only in 2% of patients versus almost 8.5% in non-surgical group. And then they said that reduction happens in all types of cancers, but maximum reduction in breast cancer, where it was in 1.6% of the patient in surgical patients versus 6.3% in non-surgical patient. So which is almost 25%, 75% reduction in cancer in post-bariatric patients. Now we come to specific cancers. So these are all evidence-based, that there is significant reduction in all obesity-related cancers, but generally benefits are not seen in men. And then they have shown that 42% reduction in melanoma, which is a skin cancer, and hematological cancers or blood cancers in women. Again, this benefit doesn't accrue to men. And then there is another study which says that there is 14% reduction in cancer risk, especially breast, uterine, colon, and pancreatic altogether, for every 10 BMI weight loss. So if somebody's BMI was 40 before surgery, it has come down to 30. The possibility of cancer reduces in that woman by 14%. But again, this benefit is not so much in men. So first thing that we need to realize is that cancer-related benefit happens because of the hormonal issues that accrues. One of the men's cancer has been found, that is the prostatic cancer, which also benefits. But primary benefit happens in women. And this is a study which was done, published in 2014. They followed 1 lakh patients who had bariatric surgery compared to 1 lakh patients who did not have bariatric surgery, meshed groups. And they found after bariatric surgery, 400 of them had cancer compared to almost 1,400 without bariatric surgery. This is again a long-term follow-up study, and which is quoted repeatedly. So I think this goes on to show uterine cancer on the endometrial cancer, as Dr. Advani was quoting. Now, what are the mechanisms of cancer improvement? Obviously, weight loss is one. And then the metabolic changes that happen, that the insulin levels go down and the cancer promoting factors also go down. And that leads to the improvement in the cancer incidence after surgery. Now, again, it's almost the same study as what Dr. Advani has quoted, that obesity and abnormal glucose metabolism leads to worse prognosis. So if somebody is obese and develops cancer, the survival is less and the recurrence is more. While bariatric surgery, if it is done, then in cancer survivors, so if it is done in cancer survivors, it also leads to successful weight loss. So it may not help them afterwards. So if somebody had a cancer, they have survived, but they are still overweight, and bariatric surgery is offered to them, then it also leads to successful weight loss. Now, what are the various factors which can affect cancer prevention. Obviously, gender is probably the most important because it is seen that these are hormone-dependent cancers like breast cancers or uterine cancers. And in men, it's mostly the prostatic cancer which is affected. There is no substantial, so there are different studies. One, the mostly people say that there is no relationship with the amount of weight loss. While other studies, which I have already quoted, is that if there is a 14% cancer reduction for every 10% BMI loss. And then again, there is no difference between different types of surgeries. So whether somebody does a sleeve gastrectomy or undergoes a gastric bypass, the benefit on cancer is the same. So it's more metabolic changes which happen in both surgeries, which leads to improvement in cancer, reduction in cancer risk. Now, besides this, it has also been seen in this particular study where there were 72 women who were more than 40 BMI. They were offered either a bypass or a sleeve. And they found in these patients, reduction of endometrial proliferation markers. And in 10 women at the time of surgery, they did a biopsy. And they found 4 of them having endometrial carcinoma, early carcinoma, and 6 of them had atypical hyperplasia. Out of these 6 patients, 5 of them, the hyperplasia reduced or resolved after bariatric surgery. So this is very important to realize that even patients who are in an early stage or pre-malignant condition can improve after bariatric surgery. Now, there are, as far as cancer prevention is concerned, now every patient doesn't develop cancers. Every person doesn't develop cancer. So it has been established that if somebody does 71 bariatric surgeries, then it will avoid 1 new cancer. So that means if our program is doing 250 surgeries a year, we are practically avoiding 3 new cancers in this city of Mumbai or wherever the patients are coming every year because they are benefiting. So friends, cancer prevention is an added benefit of bariatric surgery, is not a primary target. A surgery cannot be offered to somebody only to prevent a cancer. Bariatric surgery cannot be offered to somebody, but it is definitely offered for various acute things. And this is a collateral advantage that the person can have a benefit in terms of reduction of cancer. So to reduce cancer risk, as Dr. Advani said, bariatric surgery should be considered at a younger age, because already the changes start happening at a younger age. So the benefit of the bariatric surgery especially accrues to those where surgery is done at a younger age. Now, there is no line drawn that you should do surgery before 40 or before 20, but it goes on to show that earlier the surgery is done, the better the benefit in terms of cancer prevention. To conclude my slide, I'll just show you this is a senior lady whom we operated, severe diabetes, obstructive sleep apnea, blood pressure, and was 92 kg and is about 62 kgs after surgery. And this young boy who was 144 kgs and within a year has come down to about 69 kgs. So the change is so substantial. And obviously, we cannot have pictures of people who have cancers, but because it is a very long-term follow-up that is required. But bariatric surgery does help people in substantial weight loss, metabolic changes, and in turn, which will lead to reduced cancer risk. One caution that I would like to tell everybody, that post-successful bariatric surgery, don't think your cancer risk has completely gone. Cancer risk reduces to that of a healthy, normal weight person, and it is not completely eliminated. So whatever cancer prevention or screening recommendations are there on the city-wise or nation-wise, and who knows it better than Dr. Advani, and we'll probably talk to him later on in the question and answer session, they must be followed. Just because somebody had bariatric surgery, do not think that you are cancer prone or you are shielded from cancer. Your higher risk of cancer has been reduced to that of a normal fit person, and now you should live your life normally. So thank you so much, and I'll be very happy to take questions. Amrit, you are muted.
Thank you, Goel sir. Thank you so much for that enlightening talk, showing very clearly how weight loss after bariatric surgery has such a lot of benefit in reduction of risk of cancer. Thank you for your talk. We have a lot of questions, so I'll try to cover as many as possible. First one for you, Goel sir. This is not to do with prevention. So if someone has had a particular cancer, can they undergo bariatric surgery for weight loss?
Yeah, so there are two things, and one of them is that if somebody has cancer and is obese, should we do the surgery on an urgent basis? No. So cancer treatment deserves priority and must be done, and only when the person is a cancer survivor and is established as a cancer survivor, then one can think of doing surgery. Yes, we have also operated on many patients who are cancer survivors, and where the oncologist says that now this person can be offered bariatric surgery and the risk of cancer recurrence is not very high and the person has been cured or is in remission of cancer, that is the time when we do a bariatric surgery. Yes.
Oh, thank you, sir. So one question for Advani, sir. So we know that there is some amount of genetic susceptibility to obesity. So if the parents are obese, it is likely that the children are also going to be obese. So are these people also prone to cancers? So like obesity has some genetic predisposition. Do these cancers related to obesity also occur in the children? And if is it so, what measures can be taken to avoid? Sir, you are muted, sir.
Yeah, obviously, the cancer is a multifactorial disease. It's not a single factor related. Obesity is not the only factor which predisposes to the cancer. There are so many other environment, diet, and the habits, the way you live. Everything is a multifactorial, and genetic is also one of the important factors. Definitely, it's one of the most important factors. There are very few recognizable gene defect, like we know BRCA1 and BRCA2. These two genes, they can have a predisposition to the cancer development. That is very well known, established fact.
I'll take it.
Now, the question of diabetes, obesity. Again, I'm sure obesity in the family also must be multifactorial. It can't be single factor that the father or mother is fat and obese and therefore the children are. No, it's nothing. I mean, the food habit in the generation is same. Their activities are same and therefore everybody is fat. So I think you cannot really split these things. If you are obese, whether it's in the family, you are running, it's related to the something. Genes may be very possibly related to that, but I think it's a multifactorial. Both cancer as well as the obesity, both of them are multifactorial.
Okay, thank you, sir. Yes, also you wanted to add to that?
Yeah, so basically the thing is, Dr. Advani has very nicely mentioned about the cancers. Obesity is again a multigenetic, so there are almost more than 50 genes which are identified to cause obesity. So whether those genes are common to cancer, particular cancer is very difficult because to establish, because it is not even established which particular gene has more major factor to cause obesity. So when we don't know that, then whether that particular gene is also seen in patients who develop cancer is, I think this is a research in evolution, and we'll probably have an answer maybe 5-10 years from now.
Okay. Advani sir, is there any dietary advice for prevention of cancer? It's like one of your slides, you said 30% of cancers can be prevented by proper diet. So what does that exactly mean?
Yeah, I think The word I used in between during the talk, I did use the word healthy diet. No, nobody has a definition of what is a healthy diet, and everybody has been grouping. And I just sometime I hate all these people, so-called the nutrition people. They give the way they write the diet. One moti of this, one moti of this at 7 o'clock, 9 o'clock, 12 o'clock. I say it's crazy. I mean, it can drive you crazy. So the most important thing is to really adapt to a diet which we know that is healthy. You like if you see how the people, the cancer incidence, or even for that matter, obesity incidence is low before, and it is increasing day by day. Why is it obesity increasing? Why is the cancer increasing in there? It's because we are changing. And what are we changing? We are changing to the fast food. Very clear. You eat fast food, there's a good chance of developing the obesity. There's a good chance of developing the cancer. So I think these are all related to the diet, and diet means healthy diet. Healthy diet means good proportion of the fruits and salad. I strongly believe in that. That the with every meal you are eating, there should be one plate of the pure vegetables or the fruits or salad. With every meal, whether it's a lunch or dinner or breakfast, take one plate of the fruits. That's also very healthy. So, and also avoid, I'm not saying totally avoid the fat intake. No, eat reasonable so that you are not, don't put on the fat in your body. The most important thing is that you should avoid all these fatty diets, which are responsible for increasing the adipose fat cells in our body. And the at least the average amount of the carbohydrate, proteins, and the fat in a respectable position you can really do. So I think the most important thing is the healthy diet. And I think if you want to see the healthy diet, you should visit Kerala. I can tell you that. You will learn how healthy diet they are eating, particularly in villages. Don't go in Cochin. Cochin, they'll be eating everything. But you go to the village and you find out. Just see what they are eating. Hardly any fat. All low calorie food. Nice. Yes, and all they have plenty of greenery, plenty of fruits, everything in plenty. So that's where you will really enjoy the healthy diet.
Thank you, sir. One question for Dr. Goel. Sir, for a bariatric patient, one of the things we were talking about was reducing the risk of future cancer. But is there also, if suppose they do get cancer in future after bariatric surgery, is their survival better? So they have lost weight. So do they have a better survival advantage post bariatric surgery for any cancer?
Yeah, definitely. I mean, that's what Dr. Advani also mentioned, that the disease risk reduces and the survival advantage will be there because there are various parameters in this. Let's say the breast cancer, which is the commonest. So one is that cancer can be identified early. So person can feel the tumor early and it can be identified early. And then the treatment can be offered early, and since the hormones are normal, the possibility of survival is more. So I think it's a combination factor, and it's not related to bariatric surgery alone. It's also a weight loss issue. So ultimately, we are talking of weight loss and metabolic changes. And if they are normal, definitely the survival advantage will accrue to the patient.
Thank you, sir. I actually had a similar question for Dr. Advani, sir. Sir, do you feel between obese and non-obese people, the detection rate or rather the chances of detection is more difficult? What technical difficulties do you face in management of obese people with cancer versus lean people?
Yeah, I think there is a difficulty because, like I'm telling you, the chance of detecting the breast cancer is definitely low in the obese people because there's sometimes a small tumor in the breast may be so deep that you can't feel it. While in a thin, lean lady, you can easily feel. They can easily feel. The patient can detect them. But in a fat people, they cannot feel anything. So that's, I think, there's a difficulty of early diagnosis in their condition.
And even about their treatment and the way they follow up, is the overall outcome worse if they were on the heavier side?
Yeah, I think the problem comes up with everything. Like for the surgery, they are high risk. Obese people are high risk for the surgery. They are high risk of catching the infection post-operatively. And similarly, when it comes to the radiotherapy also, there's a high chance of lipid necrosis and producing a problem. And same way, even with chemotherapy, it's impossible to get their veins. We put the port and IV line and then try and give them. But the another important factor which happens in the is the calculation of the dose. I think it's a phenomenal job to calculate the right dose for a particular patient who are obese because you can give them either overdose or you can give them underdose and you don't know. And there are some formulas here and there, but they are not real formulas. They can't calculate properly. So I think at every phase there's a problem.
That's very lucidly put up. On one hand, the risks are more of getting a particular cancer, and on the other hand, detection is harder and treatment technically there are so many pitfalls and challenges.
Yeah.
So I don't think there is any question left on that front. That definitely it is something that has to be tackled, rather prevented than treated. Definitely prevention better than cure. That. So one question for you, Goel sir. One of the mechanisms discussed for obesity and cancer was insulin resistance. So do we extrapolate the same to even people who have only diabetes, who are not morbidly obese or who are lean diabetics per se? Do we say even they are at a higher risk of cancer because they are also probably suffering from insulin resistance, which was one of the mechanisms?
That's a tough question, really. So I think I don't have a specific answer to this question. It's not a medical science is not always 2 plus 2
Yeah.
because there are multiple factors, and because the insulin resistance is one factor and hormone is like estrogen is another factor. So a morbidly obese person, the insulin growth, the cancer growth factors are there, and there are higher estrogen, and that's why the benefit, the cancers are more in women, these hormone related cancers, and the benefit is also more in women. So I think I don't have observation. Maybe Dr. Advani might be able to answer this. Does he see the same situation in lean diabetics?
Advani sir?
Yeah, I think that sort of linkage is not there. As I said, it's a multifactorial. So if you look at the obesity, it's not that it alters only one. It alters only the insulin resistance. Not at all. It alters so many things which we know, and probably so many things that we don't know.
Absolutely.
But the important thing is the hormone. If you look at all the cancers which are related to obesity, they are hormone related cancer. Breast cancer, endometrial cancer, ovarian cancer, they are all hormone related. And therefore, I think it's a multifactorial. So if you have only one factor, insulin resistance, maybe it will do not really that much of the impact. So you may not observe that thing at all.
One other question for Goel sir. Sir, does bariatric surgery increase the risk of any cancers? Like colorectal cancer is one proposed.
Yeah. So, Amrit, it's very straightforward. Ideally, the risk should decrease Colorectal cancers are more related to fiber intake. So if the fiber intake is less, the risk of colorectal cancers are high. One of the factors for colorectal cancers. So what has been seen in some studies which have come after bariatric surgery, that in absolute numbers, the colorectal cancers are less, but when they adjust it, statistical adjustments are done, they find in some studies the risk of colorectal cancers indeed increase. And it is mainly attributed to low fiber intake. And that is like, I'm not defending bariatric surgery, but that is like saying that patients after bariatric surgery will have more more deficiencies. Now, these are related to follow-up. If person is taking vitamins, nerve deficiencies do not happen. If person is having enough fiber in the diet, the risk of colorectal cancer doesn't increase. So there are studies both ways, but yes, the only cancer where it has been found that the possibility is higher is in colorectal cancer. And the only major explanation that is given is that some patients, despite being advised, do not get enough fiber in the diet, do not consume enough fiber in the diet, and that can explain that.
And sir, again, I will bring the hormonal part. We have seen that most of these obesity-associated cancers are because of hormonal changes, the adipokines. And we know that bariatric surgery kind of normalizes the hormones. Would you say that it is this hormonal change, apart from the weight loss, that has this prevention or preventive benefit for obesity cancer?
Yes, certainly. I mean, that is one of the mechanisms. So we know that adipokines, which are like leptins and all, play an important role. And once those changes are reversed because of the reduced sizes of the fat cells or adipocytes, it is likely to be one of the factors. But nothing can be taken in isolation. That is the key.
Right.
So whether it's insulin, whether it's adipokines, whether it's estrogen, or just weight loss, all these factors play together a role to reduce this risk. Yes.
Thank you, sir. So one question for Advani, sir. It's not to do with obesity, it's more to do with cancer. What tests do you recommend annually for males and females, and at what age to rule out cancers, common cancers?
Yeah, I think basically the screening technology only can detect at early stage and reduce the mortality due to them if it is more common. Rare diseases cannot be detected early diagnosis by any screening technology. So the commonest in female is usually the breast cancer, ovarian cancer, and cervical cancer. Three common cancers in the female. So for that, after the age of 40, we advise the self-breast examination by the physician, and if necessary, mammography or nowadays MRI of the breast. Similarly, for the cervix cancer, we do regularly pap smear every year, and that can detect very efficiently. And because of that, I think the number of cervical cancer has tremendously come down. And I think simple ultrasound or sonography can also detect the ovarian cancer at an early stage if it is done regularly. So I think in the females it's quite easy. In the males, I don't think there has been really a major benefit. Even in the lung cancer high risk group, there also the role of screening is doubtful. Only place where it has been very helpful is the PSA level for prostate cancer. After the age of 50, all of us males should get the PSA done every year. And that can really save the life. Because we see nowadays so many stage 1 limited stage disease, and they are getting cured completely.
Thank you, sir. Thank you so much. One question for Goel, sir. So, after bariatric surgery, there are a subset of people who regain a significant amount of weight after some years. So, for these people who have regained the weight, is their risk now again same as a normal obese person of getting cancers?
Amrit, I have not seen any study of this kind.
Okay.
The challenge of these studies are, especially in risk of cancer, is very simple. You take a subset of patient and you have to have a control group. So otherwise you will not know how much the risk has reduced. So now you have two groups, and you need to follow them for at least for 10 years to find that the number of cancers in this group is 150, another group is 120 or 130 or 100. So to find this in people who have gained 10 kgs or 15 kgs and to follow them for 10 years is probably, I don't foresee such kind of, one can make an assumption, but one will not be scientific in that. So the fact remains that even with weight regain, most of the metabolic changes persist. So if somebody has gained 5 kgs or 10 kgs, the insulin resistance doesn't go up. So there will be still some benefit of bariatric surgery in terms of hormonal changes in those patients. So to put it simply, I don't have the answer for this question.
Okay. Thank you, sir. Advani, sir, there are two questions. They are kind of similar. One question is, we believe that when you get cancer, you're going to automatically lose weight. Is it so? Do all cancers lead to weight loss? And the second thing is, in a normal person, how much of unintentional weight loss should alert you to undergo examination?
Yeah, I think weight loss is one of the common symptoms of the cancer. And all of us, we get sort of signal that weight loss, we call it unexplained weight loss. See, that's very important to understand. If somebody is diabetes or he is obese and he's trying to lose the weight, you can't say that that's because, we have to search for the cancer. He's intentionally reduced these things. It so happens sometimes, we see occasionally such patients. He says, well, he thought that he's losing weight because he had an intention of losing the weight. And he lost the weight and didn't bother about it. And then came with the advanced cancer. But that's very rare. So I think unexplained weight loss definitely should be looked into it. We know there are certain types of the cytokines which are secreted by the tumor, and they produce the anorexia and the weight loss. And second question.
Are there any cancers where we don't see much weight loss?
Oh, there are many. One of the thing is neuroendocrine tumor and stage 4, extensive liver metastasis. They are absolutely fit and fine, walking, moving, zero weight loss. So there are many cancers. I just gave you one example where the weight loss is almost nil. So I don't think that the weight loss is there in all the cancers. But in fact, we know some of the cancer is always there, like colon cancer. Weight loss is very, very common. Stomach cancer, weight loss is common. Not in the lung cancer. It's rare in the lung cancer. So we know roughly. So if the patient comes to me and he is pancreatic cancer, severe weight loss. So a patient comes to me, he's got an extensive liver metastasis, and I find he's healthy. I know that this is not an adenocarcinoma of pancreas. It's probably neuroectodermal tumor of the pancreas. So all of us develop this sixth sense whereby we can diagnose. And sometimes people who have not worked in this area, when I tell them like that, they get surprised that you could diagnose on clinical basis. You don't. It's just that how it's related to the weight loss. Certain cancers have a weight loss. Many cancers don't have the weight loss.
So I think that's a very clear message for all of us. We always have this myth that weight loss equal to cancer, and if you're healthy, then you cannot be having a cancer. I think you have very clearly stated that. There is one more question. What advice do you give to people with cancer to improve their immunity? Like if they are going to undergo chemotherapy or post-chemotherapy.
I think the word immunity, most of the people don't understand.
Yeah.
I'm telling you, nobody understands what is immunity. All these people, you go to the Ayurvedic, homeopathic, say, what are you giving? Oh, I'm giving the patient the immunity to increase his immunity. So what are you increasing? What immunity? So they don't understand. Only they have heard the name immunity, and therefore they use the English word without knowledge. So I think immunity, cancer patient, if you look at it carefully, and I have seen lakhs of patients, they don't have lack of immunity. It's a myth that they have lack of immunity. Where the cancer patient comes with a recurrent pneumonia? Never.
Right.
Where they come with a recurrent urinary infection or recurrent colon infection? Never. So there is no immunity loss. What is lost probably is the immunity directed towards the tumor tissue. That is one factor. And we know now that how it is lost. We have understood the mechanism. There's a factor called PDL1. And PDL1 is a checkpoint inhibitor. And PDL1 is overexpressed by the tumor tissue. And because of that, our immune mechanism is unable to locate the tumor tissue, and the tumor grows. You understand? So I think people have to understand that we are not trying to, there's no immunity loss. It's a tumor-specific immunity which is impaired, and therefore the patient develops the cancer.
And sir, apart from serum PSA, are there any blood tests you commonly recommend for screening apart from PSA?
Yeah, of course. I think, like for liver cancer, we do alpha-fetoprotein. For testicular cancer, alpha-fetoprotein and beta-HCG. For pancreatic cancer, CA19.9. For colon cancer, we use the CEA, carcinoembryonic antigen. And there are many for breast, 15.3. But they are not really specific, but they are more helpful to follow up and see the response to the treatment.
Okay. Thank you so much, sir. I think I've covered most of the questions. There are a few related to how obesity affects cancer cells formation, which I think you covered very clearly in your presentation. So I think most of the questions are covered. Dr. Goel, sir, any final remarks from your end? Sir, please unmute, sir.
Yeah, Amrit, I think it was one of the most informative webinars that we have done. And one thing that I would like to ask Dr. Advani in continuation of his last answer, he mentioned these the tumor markers. They are more for follow-up. So they have just to make it very clear to the audience, they have no role in detecting a cancer as a screening tool, sir. Is it clear?
Yeah, to some extent. Basically, I can tell you that suppose one of the tumor markers is positive. I will never diagnose that this is a disease. I say suspicious. So you do other tests, imaging technology, biopsies, and prove it before just making the diagnosis on that this is a marker raised and therefore diagnosis clear cut. Let us start the treatment. Not at all. That will not be acceptable, not only in the upfront situation, but also even for the relapse situation. Even the patient will get the relapse, and the relapse diagnosis is based only on a marker, not acceptable. You have to show something, relapse, that physical imaging, then only you call it. So there are limitations of all these markers.
Yeah. So thank you so much, sir. That was a wonderful explanation of all the issues related to obesity and cancer. And I am sure, this will help a lot of people and the family physicians who are in a day-to-day practice seeing patients who are coming with hypertension, with diabetes at a young age, young girls and boys who are 18, 20-year-old and they are obese, to at least emphasize that it's not only their blood pressure or periods which are important, it's also long-term risk. They can emphasize to the parents that the long-term risk of cancer can be reduced. So Amrit, please, over to you.
So, thank you, sir. Dr. Advani, sir, any final few words from you?
I think I really learned a lot about the bariatric surgery. Normally we don't know much because we hardly listen such a subject, but I think it's good that we know now. And only thing for the obesity for us, the treatment was diet control. But today I've learned that how the surgery can also effectively control the obesity. So thank you very much for this opportunity.
Thank you so much, Advani, sir. Yours was a very enlightening talk, an eye-opener for most of us, I should say, and it was very lucid. So everything is like crystal clear. Thank you, Goel, sir, for your talk. Thank you, everyone, for joining us. We will be seeing you again next Friday, and that is going to be a webinar on obesity and pulmonary disorders. So we hope to see you then. Take care, everyone. Thank you for joining us.
Thank you.
Thank you.